All right. Good evening, everyone. This is Jeremy Davis. I'm here to discuss with you as part of the GAP MASLD Community Network sponsored by Madrigal Pharmaceuticals. We're going to discuss MASLD and MetALD. Again, I'm Jeremy Davis. I'm a nurse practitioner out of Shreveport, Louisiana, a gastrointestinal specialist, and it is my honor and pleasure to be able to present with you tonight. Here is a QR code to record the attendance for this meeting. Feel free to utilize this on your phone or any QR code device you have. This just basically lets those that are sponsoring the meeting know that we had some attendees. So we'll begin with a case study. This is our patient. This is Miss Ashley. She is a 52-year-old Caucasian female who was referred for evaluation of an abdominal sonogram that showed mild hepatomegaly with increased echogenicity consistent with steatosis. She is feeling well without any complaints at the time that we visited her during today's clinic visit. So a little bit more information about Miss Ashley. This is her past medical history. She has polycystic ovarian syndrome, hypertension, as well as hyperlipidemia. Social history, she drinks 2 glasses of wine on average a day. Medications include amlodipine, atorvastatin, multivitamin, and milk thistle. And on physical exam, she has a smooth, non-tender liver edge. Vital signs, she has mild hypertension. Her blood pressure is 140/78. Her pulse rate is 76. Her temperature is 98.4. She weighs 161 pounds. She's 5'2" in height, and so her BMI is 29.4 kilograms. Lab work, ALT is 46, AST 55, ALK phos 140, total bilirubin 1.2, platelet count 210,000, hemoglobin A1C is 5.9%, and triglycerides are 185. We'll talk about the importance of what these labs actually mean as we go further through this discussion. So Miss Ashley did non-invasive fibrosis assessment with FibroScan, and her kilopascal score, which is consistent with estimation of fibrosis, is equivalent to 11.4 kilopascals, which in turn is consistent with F3 fibrosis or significant fibrosis. Her CAP score is 310, which is consistent with severe steatosis. So right now, you can assume that she has steatotic liver disease with F3 fibrosis. When we think about steatotic liver disease, this encompasses a whole spectrum of disease states within the liver, but this also includes fatty liver. So when you think about this, you're thinking about metabolic dysfunction associated steatotic liver disease, used to be known as NAFLD, and also metabolic dysfunction associated steatohepatitis, which we also call MASH, which used to be called NASH. So when you look at the center piece here in the middle, you see this MASLD and increased alcohol intake MetALD component. And so what you see is a little breakdown of daily alcohol intake versus weekly alcohol intake. Now, one thing that is asking about is how many average daily alcohol intake in grams. So what we think about as far as grams, a single alcoholic beverage may equate, it's equivalent to 14 grams. So if you do the math, so 14 grams is equivalent to 1 drink. So the thing to think about is MASLD predominance is going to be on the lower spectrum of alcohol intake, and the higher you get, the more predominant alcohol liver disease can be associated with this. When you think about working up a patient with elevated transaminitis or transaminases, you want to make sure that you're understanding exactly what's going on. You want to make sure that you rule out drug-induced liver in any type of liver injuries, monogenic diseases, or any other miscellaneous causes. And you want to isolate a culprit before you just assume that there's MASLD or alcohol-related liver disease. So this slide is basically illustrating the amount of alcohol that some may consume, as far as if they have a beer, maybe a heavier beer, a glass of wine, or fortified wine such as sherry or port wine, or even liquors, all the way to hard liquor such as whiskeys, brandy, or cognac. But understand that this is a typical serving size of alcohol content in standard American drinks. And again, 14 grams is going to be your equivalency for all these alcoholic beverages. So something easy to remember, 14 grams for a standard drink of alcohol. Interestingly, it's across the board regardless of type of alcohol. So I guess the key point there is just because somebody says they drink beer, that still counts. Now, some of my patients say, I don't drink alcohol, but I drink beer. But we basically disclose with them, hey, this is under the same corporate umbrella as far as alcohol. So when we think about key pathogenic mechanisms and dual etiologies, so what we're discussing here is your metabolic risk factors or fatty or MASLD risk factors and alcoholic related liver disease disruptions. This is something that you want to make sure that you're paying attention to. So with patients that may be at risk for fatty liver disease, I'm going to go back a slide real quick, if it'll let me.
Jeremy, I think someone's in the waiting rooms. Do you want me to let them in?
Yes.
Okay, sorry. I thought I took it back for a second just to yeah.
Hey, would it be, I could start over if you want, if somebody's in the waiting room.
Would you want to? It's up to you.
Yeah,
However,
I don't mind. I don't
okay.
mind.
I'm gonna let them in.
Okay.
Perfect. Hello, Claudia. Welcome. Jeremy, I'm gonna give you remote control back, and then if you want to.
Yeah, can we just brush it back to the beginning?
Yeah.
Yeah, why don't we do that?
Okay. All you have to do is click the screen and you'll get control back.
Great. Hey, Claudia, can you hear me okay?
Yes, you sound great.
Can you see me okay?
I can.
Can you see the slides?
Not yet.
Hmm.
I can. I think it was my computer.
Okay, so you can see them?
Yes.
Cool. Thanks for attending. So basically what we're doing this evening is Madrigal has sponsored us to do a community network outreach regarding steatotic liver disease or MASLD. And tonight's lecture is basically looking at metabolic associated steatotic liver disease, also known as what we used to call fatty liver, MASLD, or NAFLD and NASH. And then we're going to discuss a little bit as far as metabolic alcoholic liver disease. And so these slides are going to help us kind of differentiate, well, what's legit as far as alcohol consumption when it comes to fatty liver disease, and what pretty much is something you think about as far as when somebody truly has alcoholic liver disease. So there will be a little bit of a breakdown on these slides tonight. So here's a QR code that you can use to record your attendance for the meeting if you wanted to do that. I'll leave that up here for a second. And let me know when you're ready.
I'm ready.
Okay. All right, so we're starting with a patient. This is somebody you may commonly see in the practice. This is Miss Ashley. She's a 52-year-old Caucasian female who's been referred for evaluation of an abdominal sonogram showing mild hepatomegaly and increased echogenicity consistent with steatosis. She really offers no complaints during our encounter. Her medical history is consistent with polycystic ovarian syndrome, hypertension, as well as hyperlipidemia. Social history, she claims to average 2 glasses of wine a day. So probably stressful job or what have you. We've all been there a little bit. Medication-wise, she's on amlodipine, atorvastatin, a multivitamin, and milk thistle. And on physical exam, she has a smooth, non-tender liver edge. So when we think about vitals, blood pressure, could it be related to the fact that she's coming to the clinic to discuss something? She has no idea why she's there. It's a little bit elevated. Her pulse rate is 76, not respiratory rate. She's afebrile. Her BMI is 29.4. As far as her labs, what's been offered to us, her ALT is 46, AST is 55, alk-phos 140, total bilirubin 1.2, platelet count 210,000. Her A1C is actually okay, but her triglycerides are just a little bit elevated. So one thing that I'll point out to you, so when you see an AST and ALT ratio inverse, sometimes you have to think a little bit about alcohol use. A little reminder as far as the bilirubin. If you see somebody, I know that some reference ranges on the total bilirubin, this may look like a normal reference range, but depending on certain labs, anything greater than 1.1 may be a little bit elevated depending on the reference point. So the thing is to fractionate that to assess for Gilbert syndrome. Just little tidbits of information. So Miss Ashley ended up getting a FibroScan, and what we see is that she does have significant steatosis, equivalent to severe steatosis, based on her CAP score of 310,000. The reference range, anything greater than 268, is considered a severe steatosis. And kilopascal, which is measuring fibrosis, is equivalent to significant fibrosis or F3 fibrosis. So when we think about steatotic liver disease, we have to keep in mind the fatty liver component, the metabolic dysfunction associated steatotic liver disease, or MASH. And then you also want to look at alcohol and pay attention to alcohol consumption. And not all of our patients are very willing to offer up how much alcohol they actually consume. Sometimes they'll say, I drink a little bit. I may drink a little bit on the weekends, but not every day. But if they offer you some type of suggestion of, like our patient, Miss Ashley, she's consumed 2 glasses of wine a day, give or take, then we understand that 14 grams of alcohol is equivalent to 1 drink. And so she's averaging, if she's having 2 drinks, so that's 28 grams. So she's averaging maybe this 20 to 30 reference range. And weekly, you just think about the number of days that they offer that they drink and just multiply that by the days of the week. And that'll kind of give you your rough average as far as how many alcoholic beverages a week. But this middle scale is pretty helpful because it can differentiate regarding, what do we think about MASLD predominant versus alcoholic liver disease predominant. And the take-home message, which we'll discuss a little bit further, is the higher the amount of alcohol intake, the more likely chance of alcoholic-related liver disease, and not necessarily just MASLD related. But things you also want to understand and remember is when you're working up a patient with elevated liver enzymes, you want to make sure that you are ruling out other etiologies for liver disease before just claiming steatotic liver disease in general. So this slide is basically illustrating standard alcohol serving size for American drinks. And again, the equivalency here across the board, give or take, is 14 grams of alcohol. So one drink is equal to 14 grams. So one thing I find interesting is that, some of my patients, they'll come and see us at the liver clinic and they say, I don't drink alcohol, I drink beer. And so we have to pretty much say, hey, that's still under the same corporate umbrella. So, and the interesting thing about this slide is you're looking at hard liquor, like whiskey or bourbon and cognacs, and it has the same equivalency as a single beer. And so again, very important to address and stress that alcohol is alcohol, no matter how you drink it. So when we're looking at NAFLD and alcoholic-related liver disease, again, think about risk factors. So our patient has polycystic ovarian syndrome. She's on medicine to kind of help control that. She is overweight. She likely has visceral fat, but she's not quite diabetic yet based on her A1C, but she does consume alcohol intake. So what we understand is that when you combine these together, there's going to be impaired lipid handling that's going to create oxidative stress and cell death. And when you're dealing with these disruptions in the intestinal microbiome, you can have alcohol production, lipopolysaccharides, and microbiome-derived products that can create an inflammatory response, which can lead to accelerated fibrosis and disease progression. So drivers of liver disease, I want you to pay attention to the bottom of the slide. So disease drivers, your cardiometabolic risk factors, genetic risk factors, and alcohol use. Again, at the very bottom of the slide, the breakdown is, as far as alcohol consumption. So if there's really not much grams of alcohol, less than 20 consumed for females and less than 30 for males, you're looking at a MASLD picture. And what you see is, depending on the amount of fibrosis, off to the left, your 5-year risk of decompensated liver disease is less than 1%, but the higher the amount of fibrosis, the more increase of the risk, even despite the lack of alcohol intake. But if you look at the middle of the screen, you're going to see that that even with alcohol consumption, so even if it's a very modest amount that can contribute to alcoholic liver disease, your risk stratification goes up for decompensation, the higher level of fibrosis. And also, if somebody's consuming way more than 2 to 3 drinks a day, or more than so many a week, you're definitely seeing an increased probability or risk of decompensation happening at an accelerated rate, versus those that drink no alcohol at all. So this slide does a pretty good job of kind of helping us understand why we need to be cognizant of our patients and what their social habits are, especially when it comes to alcohol use. So this slide is basically looking at detection of alcohol use with biomarkers. So this was a study that was published in the Journal of Hepatology in 2022. And essentially the main concept was they did studies of patients that may be at risk for steatotic liver disease, whether they had steatosis, alcohol use, steatohepatitis, diabetic, obese, cirrhotic, or even had a poor diet. And they did questionnaires and sample collection. So the Odyssey is a questionnaire to gauge the amount of alcohol that's being used. They did some lab testing to try to understand what type of alcohol consumption was being consumed. And they paid attention to the MCV and the GGT that we're commonly familiar with. And as we know, if we see those elevated in just basic labs with our workup, we have to suspect alcohol consumption. But the interesting thing is they also did a urine for ethyl glucocoride, as well as hair testing. And what they determined was that patients that consume moderate to excessive alcohol, and sorry, these are the ways that they collected samples in order to determine if there was alcohol use or not, regardless of what the patient had said. And they found that the urine and the hair testing was pretty optimal and sufficient as far as associated with the screening questionnaire. And what they determined was that, patients, about 28.6% of the patients had alcohol consumption, even with fatty liver in these patients. So again, disclosure is everything. So there are gaps in the assessment of metabolic alcoholic liver disease. Again, when we think about steatotic liver disease, we're looking for evidence of metabolic dysfunction. Is the BMI greater than 25? Is your serum glucose greater than 100? What about blood pressure? Is it greater than 130 or over 85? What are the triglycerides? Are they greater than 150? And if available, is your HDL less than 40? So our patient, BMI was 29. Her blood pressure was 140 over something. Her triglycerides were elevated. And so you could say that she did have isolated hypertension or hypertriglyceridemia, but she does have metabolic risk factors otherwise. And so if there's an instance that she did not have isolated hypertension or hypertriglyceridemia, then you would assume that MASLD, or metabolic dysfunction associated steatotic liver disease, would be her main diagnosis. But she does have this, but she does admit to alcohol use. Now, if she did not, and if we prove that with screening tests and what have you, then MASLD is a diagnosis. But you jump over further down, and so if she had this and she said, yeah, I consume some alcohol, then you consider PEF testing. This helps us understand how much alcohol she may be consuming without her fully disclosing what's going on. So when you assess alcohol intake, and again, our clinic schedules are pretty busy, so timing is everything. If you have time, there's a little stigma of patients not really wanting to be open and honest about alcohol use, but the use of alcohol biomarkers such as a PEF test is available. I know we have it available in our clinic and we check it often. But again, keep in mind that with alcohol use, if there's more than 140 to 350 grams, a week in females and more than 120 grams a week in males, that's consistent with significant alcohol use. And PEF scoring anywhere from 25 to 200 is equivalent. So if you have this information, you can possibly make the diagnosis of MASLD with MetALD. The higher the alcohol intake, and if the PEF is greater than 200, then you're going to be looking at alcoholic associated liver disease. So we checked a PEF on Miss Ashley, and what we determined was her PEF score was 120. So this is kind of in the middle of the PEF testing. So she has moderate to heavy alcohol consumption. I did the math on the number of glasses of wine. She mentioned that she drank 2 glasses of wine a night. So I'm going to assume that's 7 days. So that's 196 grams of alcohol a week, which still would put her in the same category. So the correlation is pretty succinct. So when we think about PEF testing, we understand that you could binge drink, but you could still have PEF detected anywhere from 3 to 12 days. And the mean half-life for this is 3 days. Now, does this mean we take this into action? Well, understand that if somebody admits and takes ownership, hey, especially if they're coming to you on a Monday and had a lot to drink over the weekend, their PEF may be elevated. But if you check it in the future, and if they stayed abstinent, you may find that PEF score may change a little bit with a little bit more time. What this slide is basically telling us is that regardless of male to female in BMI, there was really not much variability as far as the scoring of the PEF. So this is a pretty reliable testing. So they did a study with alcohol use in individuals who were overweight, and basically they analyzed 97 people out of 659 that had, and they determined that there was a suspicion for metabolic alcoholic liver disease within this study. And 15.7% were at risk for MetALD. All right, so we're back to Miss Ashley again. Medical history. I think the take-home message here is keep in mind that she has hypertension and hyperlipidemia. She has polycystic ovarian syndrome, which is going to put her at risk for metabolic liver disease regardless. But when you think about alcohol and think about that slide from a few slides ago that says, as far as determining, the risk factors for alcohol and MetALD, you have to pay attention to medical history. So there was a study that looked at how does alcohol compare to placebo. They looked to see what did this do for hypertension, and what they determined overall is that blood pressure can go up greater than 13 hours after alcohol consumption, but it can decrease blood pressure up to 12 hours after as well. So there's a biphasic relationship on this. The main thing to consider here is that alcohol does have an effect on blood pressure overall. Alcohol can also contribute to hypertriglyceridemia. So again, pay attention to this. All righty. So again, bringing home the message, take home messages. So here's our presentation once again. Our patient has a PEth score that's consistent with moderate alcohol use. She has hypertriglyceridemia. She is hypertensive. She does admit to alcohol use with 2 glasses of wine a day. She does have risk factors for steatotic liver as well as metabolic alcoholic liver disease. And she does have significant fibrosis based on her liver elastography, transient elastography testing. So at the end of the day, she's going to have a dual diagnosis of, oops, that was quick. Can we go back? So it slipped past us, but basically you're dealing with MASLD, metabolic dysfunction associated steatotic liver disease, with MetALD. As far as what we need to do for this patient, recommendation, please stop drinking alcohol because this is increasing your risk for advanced fibrosis and liver decompensation. The other thing that we need to do is she is a candidate for fatty liver for Resmetirom. She doesn't meet the criteria that she's not a candidate because of alcohol use, so that's something to consider. You want to incorporate lifestyle modifications with that as well, such as Mediterranean diet, physical activity increase, and weight loss. And because she has F3 fibrosis, she is going to need to be screened for hepatocellular carcinoma with liver ultrasound and be followed in cirrhotic care. As far as further definition for clinical trials, the ideal MetALD definition for clinical trials is based on objective biomarkers. This is to overcome underreport of alcohol use, to standardize the assessment of recent alcohol use, and to certify alcohol abstinence. Again, you want to make sure that drivers of liver disease are present. So do they have one or more cardiometabolic risk factor? Is there persistence, hypertension, or hyperlipidemia after stopping alcohol use? And exposure to risk factors, are they meeting the criteria during the last 6 to 12 months? Take-home messages, the new definition, metabolic alcoholic liver disease is alcohol intake beyond 140 to 350 grams of alcohol for females a week and 210 to 420 grams of alcohol for men a week. Clinical criteria can underestimate MetALD as well as alcoholic liver disease. So make sure that you include your alcohol biomarkers, such as your PET testing. You want to make sure that your drivers of liver disease are present. So those are your 2 or more cardiometabolic risk factors. And over time, you want to reassess metabolic dysfunction. And you want to consider adequate exposure to risk factors. And criteria for clinical research should facilitate an objective MetALD diagnosis, allowing comparisons among different sociocultural realities. I believe that concludes the presentation. I thank you for your attention. For more information, you can visit the MASLD Community Network for additional disease state education and a Resmetirom webcast. We're thankful for Madrigal for the sponsorship. This is a QR code to have access to further information.